Hey again, guys. Sorry if that cut off. I almost confused myself, so I'm just gonna start from here, and hopefully this will help me upload it to YouTube a little easier as a result. But anyway, so back to protein binding versus intrinsic clearance and perfusion. So with protein binding, if protein binding decreases, then that means that the drug is not attached to that protein anymore, so the fraction unbound will actually increase. If the fraction unbound increases, that means the total plasma concentration will decrease. This is because if we look at the math here, so if we're increasing this fraction unbound here, we're increasing this denominator, and if the denominator gets bigger, the entire fraction decreases in value basically. So this will change. So and I put changes here because it can either increase or decrease depending on how fraction unbound changes. Or sorry, total plasma changes. So if the fraction unbound increases or decreases, that doesn't change the unbound plasma concentration. And that is because of this equation down here. If you look at here, we've got your fraction unbound, and then divided by, here's your hepatic clearance. If we include the low extraction ratio here, so we've got the fraction unbound times the intrinsic clearance, we can actually cancel out the fraction unbound on both the top and bottom. So now it doesn't change. So even though this might increase, these values are the same, so it's like a ratio of 1 basically. So long story short, protein binding, the fraction unbound, if it changes, the total, or the unbound concentration doesn't change, but the total will change. And that's because if the fraction increases or decreases, that changes how much of that free drug gets eliminated. Now, for intrinsic clearance and perfusion, although it's low extraction and high extraction, they kind of do similar things. So when intrinsic clearance or perfusion increase, both total and unbound concentrations decrease. This is because if we're intrinsically clearing a drug, we're just removing it, right? So if we increase that clearance, we're increasing the removal of that drug. So it doesn't matter if it's bound or total, it's going to decrease. Now, if the clearance or perfusion decreases, meaning we're not using clearance as much, we're not perfusing as well, the concentration is going to increase because now we're not clearing it, we're just letting it sit in the body. And then here are the equations again to kind of show you. So intrinsic clearance, we're going to go back down here. So whereas fraction unbound ends up on top and bottom, the intrinsic clearance is always going to be on the bottom here, so it's always going to change no matter what over here and here. So there is no cancel out, there's no ratio of 1 to 1. And then same thing for the perfusion. There's no Q on the top here, so it's basically always going to change, either increase or decrease, whether it's unbound or total. All right, so again, but with less math with words. So whenever you change the fraction unbound here, whenever you decrease the fraction unbound, the total concentration increases, but the unbound is unchanged. And then same with if the fraction unbound is increased, total concentration decreases, but the unbound is once again unchanged. That's because your body's kind of trying to keep homeostasis, so if drug starts clearing out, then more drug is going to be released from the proteins, the albumin, in order to keep kind of the same fraction of whatever it is. If it's 90% fraction unbound, then it's going to try to keep that parameter. Whereas intrinsic clearance and perfusion, if you decrease them, you're going to increase your concentrations. If you decrease those clearances, if you increase those concentrations, those rates, you're going to decrease concentrations here. And then here are the interpretations and how it relates to toxicity for your reference. All right, so now on to a question. Atenolol is a low extraction drug, and it was administered to a patient. Phenytoin decreases the intrinsic clearance of atenolol. Which of the following would be true if they were administered together? All right, so this one's going to be both A and B. So we go back to intrinsic clearance. So if you think about it, if the intrinsic clearance decreases, that means you're not removing it from the body. If you're not removing it from the body, you're increasing the concentration or retaining that concentration in your body. So not only would it increase, but the unbound would also increase because now you've got more in your body, so you have more being unbound there. or sorry, yeah, if you're not like clearing it more, you're retaining it more. All right, so on to renal clearance here. So you might want to know just generally how to calculate if you're given the fraction that's eliminated and you're given the drug dose. You want to know how much is of the compound is eliminated versus how much the parent compound versus how much the metabolite is. And I've got like general math here, but basically you take your drug, you multiply it by the fraction of elimination of, this is referring to the parent compound, and you'll figure out how much is removed as parent, and then whatever that is, subtract the drug dose minus the parent compound, and you'll get your metabolite. So here I've got like 7,000 originally, I excrete this much of parent compound, so 7,000 minus 4,200 is 2,800. Same thing here. 250 milligrams minus that is that. So renal excretion is affected by all these parameters here: filtration, secretion, reabsorption. And then I've got the fraction excreted and examples, or like an interpretation of them for your reference. So in terms of filtration and elimination, so here's just a general equation. I think you're once again going to be given this if I don't even think you're going to be tested on it, but that's just once again for completion. So just remember that the fraction unbound, so the drug that is not attached to protein, is the compound that can be eliminated from your body. It's the same as like fraction unbound is the only type of drug that can affect different parts of your body. It's the only, like if it's bound to albumin, it's not being excreted. So, and then I've got A and B here. I want to say actually I have the same graph here, but just bigger because I figured this would be too small for you to see. But generally, if a drug is like assumed to be 100% eliminated, you're going to start like right here at 0. So 0% is eliminated, and then as you renally excrete it, you're going to excrete more. If it's not 100% renally eliminated, for instance, if it just like goes through your feces, maybe bile, things like that, you're not going to start at 0 because some of it was already eliminated. So you're going to start above 0, and then you're going to then have the same like rate that you would if it was renally eliminated, but just starting a little higher there. So that is what those two graphs mean. And here's like the example. So renally eliminated 100%, start at 0 eliminated. If it's eliminated more, then you're going to, or if it's eliminated by like hepatic or like other processes, you're going to start above that and go there. And then I didn't include any practice problems of this, but you will still need to know how to calculate creatinine clearance. And so I've got like a general how to know which body weight to use, multiply by 0.85 if it's female, and there's the equation for you. All right, so for volume of distribution and protein binding, here are some different definitions. So distribution is how the drug is moved through various tissues, like does it go into the fat, does it stay in the systemic circulation, how does it work? So I've got those definitions there. Perfusion, which is the drug's dependence on blood flow to distribute. So like we talked about like hepatic perfusion, so it's like pushing drug through the organ. Perfusion can also be perfusion through your vasculature and like how well it gets through there. Whereas permeability has to do with like getting past a barrier, usually like epithelial or endothelial cells. So factors to consider, you've got the tissue, so how well does it distribute in there? Do you have a blood-brain barrier in your way? Perfusion rate of the tissue, so once again, high perfusers are the kidneys, lungs, and liver. Low would be like fat, bone, but not bone marrow. Bone marrow is like, you know, the red blood cells and where different things happen. But the bone itself, that like calcium and the osteoclasts, osteoblasts, that's not very perfusable. So disease states, protein binding, how well does that drug bind? Disease states like, are you volume overloaded? Do you have too much fluid in your body? That might dilute drug. The lipid solubility of a drug, and then the pH. So, blood, gastric. I just want you to know, I think this might be an exam question, but alkaline drugs actually get trapped in breast tissue and they get excreted. So, possibly know that. Different transporters. I just summarized the difference between AAG, albumin, lipoproteins, but they kind of like have opposite trends. So, albumin will decrease in concentration with all these like burns, trauma, etc., whereas AAG will increase with renal failure, stress, trauma, like a heart attack, myocardial infarction. And then these are examples of drugs that can work on them. But yeah, lipoproteins didn't have anything about like increase or decrease, so that's why that's blank there. All right, so protein binding. So the more a drug protein binds, the less it's able to get into tissue. So we want free drug to be able to cross into and absorb into tissue. And so here's like a little diagram to kind of show the difference between the plasma and the tissue. And as you can see here, so notice that like unbound drug got in here, but in here it kind of looks like the same amount of drug is unbound. So that once again is kind of like showing that process of even if you're removing drug, like with the protein bound drug, the fraction unbound is going to try to stay the same no matter what. So CP is the plasma concentration of a drug in the plasma, and then the fraction unbound times the plasma concentration is going to be the concentration unbound, which makes sense. So if like 50% is unbound of like 100 milligrams, then like 50 milligrams is unbound. And then only unbound free drug can be absorbed, eliminated, etc. For volume of distribution, this is one of those other equations that it's kind of better if you just like understand this equation here and then be able to say like if the the fraction free in the tissue, if that like decreases, then that makes this entire fraction bigger, so that'll increase this entire thing here, so volume of distribution will basically increase. So it's just like a play of like, is this going up or down? Is this going up or down? How does that affect the entire equation? And then I've got those examples here that Dr. Chartavadula included in his lecture. All right, so that's all I have. Like I said, I'm going to have an individual separate PowerPoint or a little how to do intravenous bolus calculations. But yeah, I hope that this was helpful. Good luck on your exams, and I'll see you next time.